our minds what to include in the report, what to not include in the report, what are the pertinent negatives that we should emphasize in the report. Should we use a structured format, or should we make it brief, or should we give a lot of details? There are a lot of questions, and all these questions are actually universal. It doesn't matter in which language we discuss them. We all want to share our ideas, our thoughts on this lecture. I personally listened to this presentation like 5 years ago, and Sara did a great job on this. She actually read a book. She got through all the literature. She made a survey to all the pediatric surgeons and pediatricians in the hospital to find out about their expectations and their preferences. So I'm excited really to hear the talk again, and I'm hoping we can engage into a discussion at the end of this presentation, and we can ask questions and hopefully find some good answers for those questions at the end of this presentation. But first of all, I want to talk about a little bit about our presenter. Her name is Sara Alshaibani. She graduated from King Saud University College of Medicine in Riyadh, Saudi Arabia in 2010. And she completed her residency training with the Saudi Commission for Health Specialties in Saudi Arabia. She did a fellowship in 2017 in Canada at the hospital of BCCH, where we met with her, and that was really a good time for both of us. And she is currently working at King Fahad Specialist Hospital in Saudi Arabia as a pediatric radiologist. And this is where we did our fellowship to refresh our memories. And this was the city where we met. And we had really good times, both socially. And this is Sara, because she's a Wonder Woman. You'll see why. Because she's not just a very good doctor dealing with a lot of issues, but has this very nice family. And she has 7 lovely kids, 4 boys and 3 girls. And she just welcomed a new baby just 1 month ago. So I'm excited to hear her talk. Welcome, Sara. Thank you for accepting our invitation.
Thank you, Sechil. That was such a lovely and very generous presentation.
Not at all, no.
No. Well, I'm honored actually that I'm honored that you actually remember the talk from 5 years ago, and I'm also honored that you want me to give it to again. I'm really happy and proud to be here, and I just hope to live up to the expectation that you just painted and deliver at least some of it at least. Should I start now? Go ahead.
Yes, please.
All right. So I will start. I will share my screen. So when I did this talk 5 years ago, I was a fellow, as just Sechil said right now, in BC Children's Hospital, and it was actually because I had seen how the difficulty in how to report. I was struggling as myself coming out of residency, going into the fellowship, and nobody had given me any structured teaching on how to present or how to write a report. And I think this is actually a universal issue that everybody is facing. So as Sechil just said, I went through a lot of search and presented this talk 5 years ago. It's still present actually. If you go to the UBC website, you can still find it there in the archives recorded. I had thought that it would be the same. I wouldn't need to do much changes now looking at it again, but right now, 5 years later, I'm as a consultant working in the King Fahad Specialist Hospital. When I went through the presentation, I needed to do a lot of changes. When I was in medical school, they used to tell us that the expiration date for medical knowledge is 5 years. So this is accurate, actually, even onto this talk. King Fahad Specialist Hospital is a tertiary care center hospital in Dammam, and it is neighboring to another maternity and children hospital. Last year, I've been working as a part-time in the maternity and children hospital. So I'm seeing both primary and initial patient presentations and the referral type of the tertiary care hospital, which are mainly oncology and transplant patients. I'm in Dammam, which is a nice coastal city here, very quiet. I'm not too far away from you guys. The hospitals are serving the Eastern Province area, as we can see here, with about a population of 5 million people, which is kind of similar to that population in British Columbia, where I did my fellowship there. It's important to know the population of patients we are serving, because those are all, or mostly, referral cases, although we do have other centers of Children's Hospital in the Eastern Province, but the tertiary care is mainly referred to our hospital. So in this talk, I hope that I will summarize the literature in radiology reporting. I hope that I will stimulate some careful thought about our reporting habits and present you with suggestions of improvements. It's a provocative talk. I'll go through a brief introduction, some literature review. I'll talk about the report in aspects of what is the report audience, what are the report elements, language, and format, with also tackling some malpractice issues. And then finally, I'll present the BC Children's Experience, which is the survey that I did in British Columbia. So as I said, when I started, I was really struggling. It is a culture amongst trainees, some of them mainly here, that when we want to present a report, we think a lot about, we just imitate what we are seeing from our seniors. We tend to copy, we learn the phrasing and rephrasing from what we're seeing from prior reports, or how the style of the co-author, the second senior radiologist with us. So no proper training is given on how to report. And sometimes it was frustrating because I would see some who are very short and brief and some who are extensive in their language, and I didn't know which is right. So I went to the origin. What is the word report? It means basically, this is in English language, but I believe it applies to all. Re from back and port from carry. So we are carrying back information to the person who asked the question in the first place. Well, this is common sense, but it's very important to put that in mind. I'm not simply dictating in the dictaphone, publishing on the computer my report. I'm actually communicating with someone. So more than a century has passed since the first radiograph. Most of you know this, first X-ray that was obtained, and how radiologists, well, actually there weren't radiologists, just clinicians at that time, would sit and try to interpret the findings. And a lot has changed now, not only in digital radiography and the PACS and the radiology information systems, but also in the imaging technology itself. We're having functional, anatomical, fetal, intravascular, all types of modalities. But what has changed with the report? This is one of the earliest reports that were present, that we could actually find. I found this in the article documented here on below, and I'll just read it quickly. It's as a letter. The X-ray shows plainly that there is no stone of an appropriable size in the kidney. The hip bones are shown and the lower ribs and the lumbar vertebrae, but no calculus. The region of the kidneys is uniformly penetrated by the X-ray, and there is no sign of an interception by any foreign body. So it sounds kind of like an abdominal X-ray looking for kidney stones. It sounds a lot like our reports this day. And here, actually, he comments on the technique. He said, I only got the negative today and could not therefore report earlier. I will have a print made tomorrow. The picture is not so strong as I would like, but it is strong enough to differentiate the parts. So still, I mean, it sounds very similar to our reports today. 1923, an article was published about the scope of the röntgenologist report. And in short, it says that there are two types of extremes of how radiologists report. One that gives basically a perfect word picture, but without meaning to one unable to interpret it. So it's just a word picture and description. It's no meaning of interpretation. So it tells much, but yet almost nothing. The other extreme is one that is just states the diagnosis, and both are not good. We want a middle ground in between. So multiple articles are there going through the literature, but it's not sufficient enough to satisfy one's learning about the topic. Mostly are just looking at surveys and asking referring clinicians about their thoughts, trying to get some suggestions from these surveys, trying to come up with guidelines and recommendations, but it is a very difficult topic to actually put guidelines to. And it is in itself challenging to find evidence on the topic. This was the book that I went through. It was about published in 2015, a guide, about 200 pages. It's not that long. And it gives some thought, and it's a really good book, actually. And I do reference it a lot throughout the talk. Another article here showed just actually, I want to show you the terminology that is commonly used in our reports. I understand your reports actually are in Turkish language. I don't know if these specific terms, something similar to them in Turkish is being used or not. But in English language, these were found to have a big discrepancy between what the radiologists thought and the referring clinicians thought meant, such as unlikely, suspicious of, consistent with, suggestive of, questionable, maybe, highly suggestive, etc. You can see they have a very low kappa value. So this tells us that there is discordance between the radiologist and the referring clinician. The only one that did show some accordance between them was the term diagnostic of. So both of them did understand the same when the term diagnostic of was used. Another article, which is recent in Radiographics, which is a very good one, actually, how to create a great radiology report. And the author has also a YouTube video about this article. And I went through it recently to update this topic, and I did refer to it a lot during the talk. I highly recommend going back to it as well. So jumping on to the report's audience, when I did the talk 5 years back, the only audience in mind was the referring clinician. And so the ordering provider. We all know that, and we'll talk about it more. But there's something that has been updated is the patients and families. There is a current trend towards involving the patients and their families more in their clinical care. So they have a lot of access to their medical records, their files, their lab results, and also their imaging reports. Here we are seeing it in Saudi Arabia, mostly in the private sector, but I believe there will be a trend also in the governmental sector to approach this direction. So this is an example of one of the private sector hospitals, and these are screenshots from a phone application of the hospital. And you can see, if you could just go here to medical and then radiology, you will find the service there, and you can easily read the report of the imaging study that was the report directly from the radiologist as is. And you can open the image online and see the picture, the image, the radiograph with the report. If it is a study such as an MRI or a CT, you can easily scroll through the whole study and see it all, in addition to reading the entire report. Another example also is this from the EPIC program, My Chart. You can see under the test results, you will get, in addition to the general lab results, you will find some MRI, whatever, CT, all the imaging, and you can read the report very clearly there as sent from the radiologist. And also you can get back to the clinician or the radiologist by messages, and you can send them a message as a patient. So this is an example of one of my relatives who's a 20-year-old healthy woman complaining of very minor symptoms of headache and some fasciculation, whatever. It was very minor symptoms. And she underwent a CT scan of the brain. And she read this report. And I'm just going to go through it with you. Mild to moderate age discordant ventriculomegaly of indeterminate etiology, possibly in association with Chiari-1 malformation. The latter, I presume he means Chiari-1, is also noted in this patient. The study is otherwise unremarkable. And the impression says as above. So she was shocked to death from this report. She contacted me immediately. Please explain this to me. She went on Google trying to find translation to what Chiari-1 is, what is ventriculomegaly. She saw all sorts of scary things there. And she's a very healthy person. And I'm sure the CT was normal. I told her, give me the images, I will see them. And of course they were normal. The thing is, I wish I could reach out to this radiologist and be more considerate in a report as such. It really shocked her, caused her, she even thought she had cancer. And then again, I mean, it could have been, even if there was some ventriculomegaly or Chiari-1, it could have been phrased in a better way. It was incorrect, there wasn't. And also the impression as above does not give any information. So this is a sample from the patient's aspect and patient and family's aspect, which we really need to keep in mind these days when we are reporting. Additionally, medical support staff are also looking up charts and reading the reports. Other radiologists are there, especially in a tertiary care center where they are following up the imaging and reading the prior imaging and the prior reports. Billing or coding staff, if it is a private sector, would also want to look into the radiology reports. Researchers, if they want to go back in retrospective studies, they're going through the reports. So terminology, specific terminology is very important in how we classify, we put it to make ease of data mining for those researchers and lawyers. I don't know if this applies in Turkey, but it's not as much here, maybe more in the US, but lawyers are also something to consider because they are non-medical and they will be looking at the reports. So this is about the report's audience. Going to the report elements, language, and format. Elements are those which are usually unified or commonly seen in most of the reports. But the most important thing here is the last step, which is the radiologist's signature. And I put contact information because I saw a suggestion in one of the articles, which I found a really good suggestion. For example, here, the signature of the radiologist, Jane Doe, and if you go and click on it, you get the radiologist's email and number, and you can contact them. I found this to be a very nice way to ease the clinician communicating with the radiologist, as well as another radiologist reading the report and finding the prior radiologist. Also, another suggestion, which is nice, to submit feedback about the report that could go spontaneously to the radiologist. It could be a very short survey as such. And I thought this was a very nice idea because the best way, and this is actually one important point in the talk to get out with a take-home message, the best way in learning about how to report is by following up your reports. Going back to the clinicians, getting feedback from them, going back to the patient's file, making sure what happened after that, was your interpretation right or wrong? I'm pretty sure most of the people do this actually, and this is the way it is learned best. So I'll talk more specifically about the findings section, which is the body section of the report. It should be ideally a very short, informative phrases based on factual observations. It's not opinionative, not detailed description, but it should give informative, good information and facts. Avoid the interpretation and the findings section. That is should be left for the impression section. If there are incidental findings, this is the place to mention them and describe them appropriately. If it is benign and nothing to worry about, it should be phrased and mentioned nicely in the findings part. Should not be repeated again in the conclusion or the impression, so as not to cause a lot of stress for something that is not important. However, if it is an important incidental finding, then yes, it definitely should be mentioned again in the impression. There should always be avoidance of usage of excessive terms of perception. For example, there are numerous enlarged nodules visualized in the right lung. You could just say numerous enlarging right lung nodules. And this may actually not be, I don't know if it is really applicable to Turkish language reports or not, or if there is some similarities with this type of phrasing. Also avoid redundancy whenever you can. Anything such as this long sentence shortened down to simply unchanged complex peripancreatic collections. It says the same, and you omit all the unnecessary redundant words that have no actual meaning in them. Always keep it organized. It's a good way to use bullets and lists wherever appropriate. For example, if you have multiple lung nodules, some are enlarging in a follow-up study, some are decreasing, you want to describe them, it's good to put them in lists. Or if you have multiple collections, put them in lists and say the largest this and that, measuring that and that. So it will keep it organized and nice to look at, and also ease in follow-up reports. The impression section is the meaning of the findings. So you will summarize and give the meanings of what you have said, and always lead with the diagnosis. For example, if you have this chronic liver disease, you will say chronic liver disease with portal hypertension seen as splenomegaly and ascites, not the other way around. So you won't say splenomegaly and ascites, portal hypertension findings in chronic liver disease, because the first words you read leave the most impression on the reader's mind. So once you start with the main diagnosis, and then you can follow with the rest. Also mention the appropriate differential diagnoses. And in this, I would like to mention one of the cases that I encountered. Being in in a tertiary hospital, we see a lot of neuroblastoma cases. So much cases to a degree that they're just very typical. The minute you see it, you'll know it's a neuroblastoma. The primary team taking care of the oncology team here usually don't ask for urine catecholamines. They immediately go for a biopsy and start treatment because that delays the management. And so one time one of the residents that I was working with stated a differential diagnosis of paraganglioma in a case of neuroblastoma. I didn't remove it because it's not incorrect. I mean, that's the way we're taught during residency. You should expect it to say it in the exam. I knew for sure it was 99% neuroblastoma, not a paraganglioma. Their primary team panicked when they read this word of paraganglioma. The interventional radiologist refused to take a biopsy until they did the urine catecholamines. So there was a delay, and they were upset. Everybody was upset. They wanted us to change the word, to remove it. And that wasn't, I mean, we didn't do that, we kept it, but they were upset. So I learned from this to next time what exactly the clinician wants, and I will give them in justifiable way. I mean, it is an appropriate differential, but if it is very clear and you don't really need to put it, it will not cause any panic, then it's fine not to mention it in the report. Avoid technical language, such as T2 high signal round lesion, T1 low signal intensity, likely suggestive of a cyst or whatever, like something like that. I mean, just simply say cyst. Think that you are speaking to someone on the phone or face-to-face, whoever is reading the report. You won't go through all the technical description. In the impression, you would simply say, this is a cyst, it's benign, whatever. You won't go through all of this technical language. Also, avoid mentioning clinically insignificant findings. Those should be in the body of the report. Additionally, avoid redundancy as with the body of the report, and make the appropriate recommendations when necessary. These are examples of redundant words. They may not be exactly applicable, of course, in Turkish language. Interval change, mass lesion, prior history. These are also examples from the article I mentioned earlier, showing reports before and after. They are the same words, they are the same meaning with fewer words, delivering better meaning. Because when you're looking at it, it's just easier. All you have there is just the facts that you need, omitting all the unnecessary talk in the, words in the report. This is an example if you want to say there is significant interval increase in the size of the aforementioned hepatic mass with increased size and number of the metastatic lung nodules in keeping with disease progression. You could simply say a large hepatic mass and disease progression of the lung metastasis. So that makes a clear, memorable, direct, and informative message to the reader. The word normal, I've seen that it causes a lot of anxiety amongst radiologists. They just cannot say, some of them cannot say normal. I don't know why they're having this stress. They put it under multiple phrases as such: no significant abnormality, relatively normal, normal for age, grossly normal. I mean, just simply say normal. If it is normal, say normal and take the anxiety out from yourself and from everybody else who's reading it. When you want to express severity, if a scale is present, then use it. If not, try to collaborate with the clinicians and develop one. For example, the scale of severity that we would think of is mild, moderate, and severe. If I were to describe a finding and say, this is mild to moderate, I would think about a certain point along this scale. However, it is not like the directions. It is not a certain point or a direction. The clinician might interpret it as a spectrum from mild to moderate. So it is important to be clear what exactly we are meaning, and that only happens by direct communication with the clinicians. So what are the most important aspects of a language of a good report? The 6 C's to be summarized: clear. This was found in a Canadian survey as to be the most valuable element of a report. Keep the report correct, definitely. A precise diagnosis whenever possible is the best in ACR standard of communication. Certainty, try to indicate the confidence level of your certainty. Try to be concise, complete, definitely, and consistent in your reporting. Not one day you're reporting an abdominal ultrasound in a method and the next day it is reported differently. So consistency is a hallmark of quality. And to sum it all up, the most important C in language is communication. It is a tool of communication. We must ensure that we are communicating efficiently with the reader, whomever it may be. And I'm emphasizing the importance of follow-up, as I mentioned before, follow-up with the clinician, follow-up about the results of the report in order for yourself to grow and learn from your mistake and improve your report. This is, nobody wants to be like this. So we know some of us are like this, and sometimes appears to be a possible borderline, indeterminate, equivocal, suspected pixel, probably of questionable significance. Clinical correlation is needed. Also for clinical correlation, I mean, if you can correlate by yourself, go ahead and do it. Don't ask for clinical correlation. If you have access to the medical file, which you can go through the lab or whatever and find the answer to your question, just correlate and come up with the conclusion you from this correlation, or pick up the phone and speak with the referring clinician and understand what they mean, and accordingly you formulate your report. Hedging is actually hiding behind terms as an idea to kind of not commit to them, using ambiguous statements in order to protect yourself. And so if there is over 90% certainty that this diagnosis is correct, then this should be in the impression, and try not to hedge using hedging terminology, such as the lungs appear clear. Are they clear or not? If they are clear, say the lungs are clear. Why are you saying they appear? you're seeing the image. I mean, and then something else such as, I mean, no evidence of density or opacity, apparent, possible, borderline. This list is all an example of all those vague terms that we tend to put in there to possibly protect ourselves. This is maybe not significant to you because, I mean, it's all in English language, but there is an initiative of providing common terms in the RSNA informatics website. There are also some reporting data systems which help to make consistent reports, such as the BIRADS, you know, in the breast and the LIRADS, etc. These could be, I mean, are encouraged to be used since it is a common language amongst radiologists everywhere. There is an initiative as well with multiple templates present in the RSNA library. These could help as just a guidance maybe to early trainees if they want to make sure that they thoroughly went through most of the things, but by no means are mandatory to follow. So jumping now to the reports format, and the format is two types, the traditional format and the structured format. I will show examples of each. This is the traditional report in which you have just, you know, all the talk is there in a literature kind of way. And this is a structured format where you have structured appearance to the report. The structured report gives a consistent organization. It's usually via assigned templates or macros incorporated in the PACS system, such as those that require a mouse click input, and you can choose from a list of options. The pros of the structured reporting is it can easily give you the information. It is very clear and it is helpful in comparisons. So it's easier to read, nicer to look at, faster in research and data mining. Some studies did show that standardized structured reports are actually better in giving clarity than conventional reports. These studies looked at these structured reports as well, and some did not like them, believing that it was a productivity nightmare and that they did impede the radiologist's productivity. So if they do not, then they are encouraged according to these studies. Again, it depends mainly on the center you are at, your audience, what do they like? So going to malpractice issues, this is an example of a 38-year-old woman who underwent routine chest radiograph, and this was the report that was issued for it. A soft tissue density in the right chest overlying the 7th rib posteriorly is seen. This could be a scar or even neoplasm. If previous chest X-ray is available for comparison, this would be most helpful. If not, then a 4-view chest X-ray may be of benefit. You can see that he found the finding, they described them nicely, but it's not a very strong language. And then 22 months later, the patient progressed to adenocarcinoma, and it was a lawsuit against the radiologist. And this case is from this article in the American Journal of Radiologists. There were multiple other cases also in the article, and it summarized that the lawsuits against the radiologists are not because of missed or misinterpreted findings. It is not because of incorrect diagnosis. However, it is mostly because of failure to report them in a manner meaningful to the referring physician. So failure of adequate communication. These are other, again, in the report, in this article, they said that the vagueness, the non-clarity of the reports was mainly the cause. Words such as if clinically warranted, if clinically indicated, may be of value, comparison with the patient's prior films is recommended. I mean, if you have prior films, immediately compare. If not, try to communicate with the patient or with the family or with the clinician to present them, act as much as you can, especially if you are facing something scary such as this lesion in the lung. Although I could understand if someone is reading 200 x-rays, chest x-rays in one day, in addition to other modalities, something you won't have much time to go and communicate. But it's really important to put this effort, especially in cases as such. Would be most helpful, maybe of benefit. Clinical correlation is recommended. So the clinicians had disclosed that if the radiologist expressed themselves more strongly in the reports, they would have acted much sooner. And so the radiologists were sued because simply of their vagueness in their reports. And that this study disclosed that 75% of claims against radiologists stemmed from errors in communication, not errors in diagnosis. Although error in diagnosis in this study was found to be the most common cause for radiology malpractice suits, followed by inadequate communication. So what happens in case if you are reading a study and there is a misdiagnosis from the radiologist in the prior one? The first thing would be is to inform the interpreting radiologist from the prior study to put an addendum. If that is not possible, dictate the finding without specific reference to it unless absolutely crucial. And always, if you are in doubt, always, at least from a legal perspective, use simple, basic language and basic terminology in a report. And remember that the reader, especially if it is a jury, if it is lawyers, it will be non-medical person. So they will not understand all the technical medical terminology. Yes, we have to use medical terminology, but as much as possible to make it simple and understandable. So going through the survey that I did in BC Children's Hospital, I sent out the survey as an email to all the referring clinicians through the BC province. I got a total of 81 responses, and the majority were from general pediatricians, some from emergency, GI, and these other specialties, as you can see, have also responded to the report, to the survey. Their years in practice mostly were above 20 years in practice. Our average number of their radiology reports were mostly between 0 and 10 radiology reports read per week. I asked them how they feel about certain comments. The first one was the radiology report is indispensable to my practice. And you can see they strongly agreed with that. I read the report as soon as it is available. Mostly they agreed with that. I prefer detailed, longer reports. And here, some of them agreed, some disagreed, or maybe mostly were neutral. I generally jump to read the conclusion and scan or ignore the body of the report. Mostly disagreed, and I was surprised because from the literature that I read, it was always stated that most of the readers will jump to the conclusion. I mean, actually, we do it ourselves sometimes. If we are busy and we're going back to a report, we just jump to the conclusion. So I was surprised that they disagreed with this statement. A conclusion does not add value to a short, concise report if it is 5 lines or less, and they disagreed with that. Sometimes, most of the times myself, if a report is short, like a chest X-ray or whatever, I mean, I would not see the value of adding a conclusion, but apparently they want a conclusion, even if it is short. So I started after that always adding a conclusion. I prefer the conclusion to be in bullet numbered format, and mostly were neutral about this, but mainly they agreed. I am occasionally confused by the radiology reports, and they were split in half. Some agreed and some disagreed, and this is, well, not very good. I often do not read the report. They strongly disagreed with that, and I'm glad that they do read them. I wonder a lot, especially the orthopods, if they do read our reports. And it's really important to collaborate with them in your practice, wherever you are, to ask them specifically do they read the scoliosis reports, or are they just doing their own measurements? What are they looking for in the ultrasound of the hip? Some of them don't even just look for the alpha angle. Some want the beta. I mean, you know, just trying to find the consistency and providing them with what they want. Not only the orthopods, of course, everybody else, but this is just an example. I believe clinical information about the patient can bias the radiologist, and mostly they disagree to that. And I'm glad, actually, because I did have the thought that some clinician might not give all the information, intending to test the radiologist, or thinking that maybe the radiologist would give a better report if they did not give them all the information. So I'm glad that they disagreed with that. I believe I am better than the radiologist at interpreting the important findings in my area of expertise, and they disagreed with that strongly. So I'm glad. I find the annotation of key images very helpful in interpreting the radiologist's report, and this is actually, they agreed to it. Key images are actually a good way in communicating with prior radiologists as well, but it seems that clinicians like to look at them as well, especially if they are nicely annotated, sizes of pulmonary nodules, or you know, arrows to the findings, measurements as well. And then just keep them for the clinician to be able to see. Standardizing language is a key element in improving report communication, and they mostly agreed to that. Consistent presentation of the report content is key element in improving reports, and also they agreed to that. These statements, I asked them if they should be included in the reports, which are measurement of normal organs, and the majority do not want us to mention the measurement of normal organs, such as kidneys. Or, I mean, we keep on measuring and always including the measurements. So if there are just normal, we could just go ahead and say normal size without actually having to write the size down. Recommendation for further imaging, and mostly they want us to recommend further imaging. However, non-radiological investigation, a lesser number want us to not recommend, but they still do want us. Recommendation for further referral, and also they still want us to recommend further referral. But when it comes to treatment, the majority do not want us to recommend further treatment. I presented them with an example of an abdominal ultrasound report, structured and narrative, and 70% preferred the structured style. The same was applied to a CT brain report. 70% preferred the structured report. Similarly, with an abdominal MRI report, the same percentage, they all preferred the structured report. And overall, their general satisfaction over clarity, content, and style was mostly they were satisfied with the radiology report. So that was actually a very good survey, very informative to myself and hopefully to the staff there. I learned a lot from it, and I did try to carry on with this method of getting follow-up from clinicians, even here in Saudi Arabia, wherever I go, and I highly advise you about this again. So the take-home messages from the talk is learning to report is not like learning a fact. It is not a box that you can check during your training. And it is a continual work in progress throughout your career. You will keep on learning, you will keep on improving, and you will keep on brushing over your skills in reporting. Again, I emphasize the importance of follow-up. So I hope that I have obtained the objectives in this talk that I mentioned earlier. At least some stimulation of thought, make you stop and think before you report next time about each and every word you are choosing and how to put it in the report. So thank you so much for listening. I hope I didn't cause anybody to snooze or sleep.
Thank you very much for this very nice lesson. It gets me every time, you know. I like to hear about the facts of reporting. And I think it's very important. I think you lived up to our expectations on that.
Absolutely.
That's very true that nobody gets a structured lecture on this. We try to pick up some clues from what we see from our seniors. And if we are in a good institution with people with a lot of experience, maybe we do better, but all of us may not have the same, you know, same uh, circumstances, so it's not standardized. So I believe everyone in training, all the residents all the fellows should at least participate in one of these lectures. I think I'm thinking about myself. I didn't receive any lectures on reporting until my fellowship, and I'm glad that you have picked up this topic. Otherwise, until this day, I wouldn't have read much about that. And I'm definitely going to read that article in RSNA. I think it will be most helpful, and I recommend everybody to do that also. Uh, it looks like we do not have many questions here. Uh, I want to encourage people to ask. I'm sure they have a lot of questions in their minds, but they're a bit shy, I guess.
Hi, Sechil. Can I ask
Hi,
a question?
yes, please.
Okay,
Okay, welcome.
thanks. Hi, Sarah. I'm Ali. I'm a pediatric radiologist at McMaster. I'm still in Canada.
Nice to
And
meet you.
yeah, and excellent lecture. I believe that reporting is as important as knowing radiology. We face the problems every day in reporting. As a non-English speaking radiologist, I think it's more challenging for us. And yeah, that I was at SickKids like 5, 6 years ago, and one of the fellows conducted a research on this, but in a different way. They reviewed the prior reports at SickKids, like 300, 400, and they realized that in their research, the number of the errors in the reports at SickKids were higher than 70%. Most of them were minor reports, grammatical mistakes or typos. The important ones, clinically significant ones, were only a very little, 1%, but it still existed. So even one of the best centers, they still have this problem. So it is important. Just last week in my hospital, in one of the reports, the radiologist mentioned that instead of calcaneonavicular, mentioned talocalcaneal uh, coalition. I mean, in the impression was wrong, but in the body it was correct. Now it has become a lawsuit, and the orthopedic surgeon operated the wrong joint. So apparently the approach was different. So now it's a lawsuit. The orthopedic surgeon is now blaming the radiologist. But yeah, that's really important. And I would like to ask you a few questions. One of them is hedging terminology. You mentioned nicely we should avoid it. For example, here they mention in the MR angiograms, they mention that there is no aneurysms larger than 3 millimeters, like in each report. So I think it's too much, right? It's because you can't do it like mammograms. I see in the mammograms, but they already know this, right? Everyone knows this already.
I mean,
And
absolutely, I agree with you. You're reporting an MRI. You're not looking at this structure under the microscope. So whatever the resolution of the MRI, you will not see below 3. I mean, what you mentioned, 3
yeah,
millimeters.
yeah, there's always going to be a limitation, right? In every test. So okay, good. So the other thing was the clinical recommendations. So sometimes I find it hard and for us to make clinical recommendations. For example, there's a brain tumor, consult with neurosurgery. So do I have to do this all the time? Isn't it like insulting the clinician because they should already know this, right? I'm a radiologist, but what do you
Yes,
think?
Absolutely. If it is a primary care doctor who referred the case, then maybe they won't. Maybe they won't know specifically what to do next step. They might panic. So you might give them the recommendation of this person needs to be referred to a neurologist or neurosurgeon or whatever. However, if it is from the neurosurgeon itself or the neurologist, then definitely you're not going to say that. So it depends who sent you the study.
Yeah, agreed. And there's also sometimes in the clinical history, they mention incorrect information. For example, the patient is 7 years old, but then you look at it, it's not 7, it's actually 9, or gender is different, or the clinical. What do you do in those cases? Do you put the incorrect information in your report, or do you correct it? How do you approach?
You mean the referring clinician mentioned the incorrect
Yes.
medical data?
Yes.
Usually, if you're sure if it's incorrect and you went back, for example, we have access to the medical records, electronic medical records. So I can check usually all the information to make sure. I call them as much as I can. I mean, it's a smaller community in the tertiary care hospital where I'm working, but I prefer always to call them and give them feedback, as I would prefer them to do the same if they pick up a mistake in my report. So I do tell them, this is, are you sure the age on the medical record says 7, but you wrote 9?
Or the patient had appendectomy, but in the clinical history, they mention check for appendicitis. So what do? Do you write it, or do you?
Oh, I mean, you're going to have to write it. I mean, because it's there, and especially in these are very annoying because they show shortage in the referring clinician. They didn't examine the patient at least. They don't know that they have an appendectomy, and they send out for an ultrasound for appendicitis. I mean, that's bad.
Yeah. Yeah. Thank you.
You're welcome. Thank you so much for your questions and comments.
And what the audience, your report is limited with what the audience understands. Like
it's like selling a product. You need to think a lot about who's buying it. It's not about how you want it to look like. It's about how they want it, because you're answering their question. It shouldn't be how you prefer it, but should be how they prefer it. It's all the end in the aim of providing better patient care. It's not just about pleasing people. It's this will improve the patient care.
And I understand that communication is the key, and we should make time to pick up the phone and communicate where necessary. And one of our participants says, thank you for your nice and descriptive presentation. As I understand, it's very important to work in close cooperation with relevant clinical branches and to develop a common language. And I think he is definitely right.
Absolutely. I agree. Yes.
From this presentation. And I was going to ask there, I think there are a lot of residents and a lot of fellows participating in today's lecture. They can also ask questions about practice, radiology practice in Saudi Arabia. If anybody is interested, this can also be a part of our conversation today. And then if there are not more questions, I'm waiting. Oh, Ali,
actually,
you have a question?
Yeah, I have a comment and maybe a question.
Yes,
I just remembered. So when you were in your lecture, there were terminology like in keeping with, consistent with. So we have the same in Turkish, and I didn't know the difference. Even in English, I didn't know the difference between them. I always thought I didn't know the discrepancy. I always thought them we were understanding the same from those terminology. For example, I was thinking that when I say suggesting, it is very low confidence. I like it's not much likely to that the diagnosis is. Or if I say consistent with, it is like, oh, I'm more confident. I always thought that. And in Turkish, we have the same thing. And I used to do the same mistake. For example, when I say in Turkish düşündürüyor, bu it means suggestive. So I always thought that the clinician will understand this, but no, I think they understand that düşündürüyor or bununla uyumlu dediğimiz zaman klinisyen the clinician will understand the same thing. There is no difference for them. And there was also one thing in Turkey. We were always taught that when you're giving a differential, mention the differentials in a list in the order that the strongest is first. Do you like? Does it work? Do they understand the same? The clinicians. For example, when I give a differential, if I say in the first place, if I say this is a tumor, and in the second place, if I say this is infection, would they understand that this is more likely to be tumor, or is there a discrepancy?
Yes, I agree with you. I mean, exactly what you said. I was surprised when I went through this part, especially the first part you said, that I would say a statement, and later on I would find out that the clinician is not actually understanding the statement in my mind. Or like you said, inconsistent or in keeping with, they would mean the same to him, but to me it would be a little bit different.
Yes.
But regarding the diagnosis, the list of differential, usually I would like to make it very, very clear when I say it, such as this tumor is most likely in this case because such and such. However, infection cannot be ruled out. I still think it could be infection. I try to communicate as if I'm actually think as if I'm talking to them on the phone, and I would just explain it to them in this way. But I would give a preference order when I'm listing it. I don't just put them by numbers. Tumor, number 2 infection, number 3 whatever. So I would like to elaborate more, just to kind of convince them that I'm really worried about this to be a tumor, but it could also be infection, so work that up as well. You know, however you find it suitable. Yeah, just as long as you make sure that it is, when you're reading it, you know, sometimes when we're writing it, it's not as the same as when we're reading it. So just pause, go back to it and read it again and make sure that it sounds how you want it to.
Thanks.
Okay.
And I've been to Riyadh actually, and I worked in Bahrain. I was close to your city, Dammam.
Oh, that's
yeah. And I had an interview in Riyadh, and I was almost going to Riyadh. Then I got the position in Bahrain.
Oh, that's good. So you've been international.
Yeah, and Saudi Arabia is like a very different perception. When you go there, you see the difference. It's completely different from the way we anticipate.
Yeah, that has changed a lot over the last years.
I heard about that too. In the last 2-3 years, it has.
It has.
Yeah.
Do you have a lot of foreign doctors working in Saudi Arabia?
There are. It's a big number, actually. Yes, we do have foreign doctors working here.
Do you have Turkish doctors there?
Not much that I have seen, actually, or worked with. Yes, mostly from the East, Indians, that kind of. Yeah, Egypt, of course, a lot. Yeah, and the Arab world, a lot from the Arab world.
Okay, and there are a few more questions. Dr. Tural Akkush asks, do you state all the radiological features of the lesions like T1, T2, W-weighted image characteristics in the findings part, and then give your differential diagnosis in the impression? Or do you use a more plain language in findings part?
No, I do state all the technical radiological descriptions such as T1, T2, etc. I do state them in the findings. I don't repeat them in the impression. So the impression is just the differential or the diagnosis. And the plain language is mostly in the impression as well. But the body of the report, go ahead and say all the technical that you need. That's how we do it. I mean,
there's a comment. In my clinical experience, I see that the clinicians lack the radiological algorithm and we have less clinical data. And one more thing is that each clinical branch look at the patient just from his clinical branch view. Yeah, I think that would be international.
It is a real bad, I mean, it's an issue actually, yes. It's again, I mean, collaboration and communication, it's really vital because we need to keep in mind, again, we're serving the patient. That's the most important thing. So we do need to collaborate better, absolutely. I agree.
Oh, he says, and he has given an example. For example, one of my patients had unilateral deep venous thrombose, and vascular surgeon tried to treat it with anticoagulant, but the patient had actually a bladder carcinoma recurrence. So he's just focused on the deep venous thrombosis, but not the main.
Yeah,
Yes, that's an issue.
it is.
Yes.
Okay. Most of the time, actually, it's us radiologists who bring the teams together because
Yes,
we're looking at it holistically. We're finding other findings. I mean, we guide them a lot, and that's our role is really vital. We're not just putting a report and keeping it go there. Especially in cases as such, I would definitely go back and call the whole team, try to make sure that they really know about this and involve the team better in the patient's care, and especially such as this scenario. Not just, I mean, our role at these cases, I wouldn't just write the report and go home. I'll try my best to make sure that they all know action has been taken, because this is the difference between a good radiologist and not.
That's a very good one. Couldn't agree more. And if we have no questions, I would like to return to Ali and ask him if he wants to do the contest part. I know that he has a contest, but what do you think, Ali? Do we have time for the contest? I think he's offline. Well, then if we have no more questions or comments, I can call it the night.
Well, thank you so much again, Sajil. This was really an honor. I'm so happy. I hope
sorry, I was muted. Sorry, like I was speaking to myself. I'm sorry. So the quiz is ready. 10 questions, 30 to 40 minutes. If the audience wants, we can do it.
Contests.
But it's in Turkish.
Oh, sorry.
That's fine. Go ahead.
He participates in all.
I don't know,
I can leave you guys. Yeah. No, go ahead.
So it's just 15 minutes. Let's do it.
No, it's 30 to 40 minutes.
Oh.
I don't know if the audience wants it, or we can do it at some other time. It's up to you.
Okay. Let's do it some other time. If